Hello everyone, welcome back. Today I am going to cover regarding tuberculosis, TB, hip. We will cover an introduction, pathogenesis of TB hip, clinical presentation, investigation, the stages of TB hip by Tuli, classification of the radiological appearance, surgical intervention, stage-wise treatment approach, complications of TB hip, and prognosis of TB hip. As an introduction, tuberculosis, TB of the hip is second only to spine. In early stages of TB hip, there is diagnostic dilemma when plain X-rays are negative. By the time definite radiological changes appear on plain X-ray, the disease has moderately advanced. The modern diagnostic facilities like ultrasonography, USG, or magnetic resonance imaging, MRI of the hip, ultrasound-guided aspiration of synovial fluid, and obtaining the material for polymerase chain reaction and tissue diagnosis must be utilized. Regarding pathogenesis and pathology of the TB hip, osteoarticular TB is secondary to primary pathology in lungs, lymph nodes, or any of the viscera. Through the hematogenous route, the bacteria reach either to synovium or bone. When it lodges first in the synovium, the synovial membrane becomes swollen and congested. The granulation tissue from the synovium extends over the bone, resulting in necrosis of the subchondral bone, sequestra, and maybe kissing lesion on either side of the joint. The bacteria may lodge first in the epiphyseal or metaphyseal region of the adjoining bones like the head or neck of femur, greater trochanter or acetabulum to start the destructive process. It may start as extra-articular or juxta-articular lesion. When the disease starts as intra-articular, it progresses fast to involve the whole joint. This picture illustrates the location of osseous origin of the tuberculous hip. 1 is the acetabular region, 2 the femoral head or the epiphysis, 3 greater trochanter, 4 the femoral neck or metaphysis region. An extra-articular lesion can also progress further to involve the joint. Cold abscess that usually forms within the joint may perforate the capsule to present around the hip joint in the femoral triangle, medial or lateral or posterior aspects of the thigh, ischiorectal fossa. The clinical presentation of tuberculous hip. There is pain in the hip, limb, restriction of movement is present in almost all the cases. Depending upon the extent of the involvement, there can be deformity, shortening of the limb, swelling, pathological dislocation, and sinuses. Tuli described 4 stages in the TB hip. In stage 1, synovitis, patient presented with flexion, abduction, external rotation, and apparent lengthening. In stage 2, early arthritis, there is flexion, adduction, internal rotation, and apparent shortening. For stage 3, advanced arthritis, patient has flexion, adduction, internal rotation, and shortening. Stage 4. Advanced arthritis with subluxation or dislocation. There is flexion, adduction, internal rotation with gross shortening. Investigation. In the endemic regions for tuberculosis, a clinical diagnosis supported by radiograph is adequate for starting the anti-TB treatment. Tissue biopsy can help in reaching a conclusive diagnosis. In the present time, MRI help to detect the early pathology in the hip joint as it shows the pre-destructive lesion like edema and inflammation. It is sensitive to detect soft tissue abnormalities in and around the joint, but MRI is not specific for TB hip. In stage 1 TB hip synovitis, radiologic features shows haziness of articular margins and rarefaction is usually frequently missed. This pelvic X-ray shows TB of the right hip. Sorry, I couldn't find X-ray in type 2B, in type 2 TB hip. In stage 3 TB hip, advanced arthritis, the radiologic feature will show destruction of articular surface, reduction in joint space. This left hip joint X-ray demonstrates the destruction of articular surface and reduction in joint space. In stage 4 TB hip, advanced arthritis with subluxation or dislocation, the radiologic features shows a destruction of articular surface, reduction in joint space, wandering acetabulum. This pelvic X-ray illustrates the travelling or wandering right hip in stage 4 disease. Another classification of the radiological appearance, Shanmugasundaram suggested a new radiological classification for the tuberculosis disease of the hip, applicable for the lesion in children C and adult A. Following radiological type suggested by him, normal appearance can be seen in children, travelling acetabulum can be seen in children and adult, dislocated hip usually in children, Pettis type in children, protrusio acetabuli, children and adult can be seen, atrophic type in adult, mortar and pestle type in children and adult. There is a relationship between various radiological types and the functional outcome. Good results were obtained in 92% of normal type, 80% of Pettis type, 50% of dislocating type, 29% of travelling acetabulum and mortar pestle type. The poor outcome could be predicted if the joint space was reduced to 3 mm or less. This picture illustrates the classification by Shanmugasundaram. In type 1, the so-called normal, the type 2, travelling acetabulum, the type 3, dislocating, the type 4, Pettis-like, the type 5, protrusio acetabuli, the type 6, atrophic, type 7, mortar pestle type. There is also type 8 that is not shown here, the unclassified type. The treatment of tuberculosis of the hip. The treatment aims at A. Control of active infection, B. Correction of deformities. C. Restoration of function. Antitubercular chemotherapy is started in all stages of presentation. So what is the role of traction? Okay, in traction, it is recommended in all patients. Skeletal traction is preferable to skin traction. In the presence of abduction deformity, bilateral traction is advocated. Traction serves the following advantages. It relieves the muscle spasm, prevents or corrects deformity and subluxation, maintain the joint space, minimizes the chances of development of migration of acetabulum, keeps the joint surface apart, whereby early hip mobilizing exercise can be started. This picture shows example of skeletal traction method. Regarding surgical intervention, A. Synovectomy, joint debridement and arthrolysis. These measures are generally taken in early and late arthritis. The aim is to decrease the tissue load and break the adhesion for a better outcome of the treatment. B. Excision arthroplasty, also known as Girdlestone excision arthroplasty, carried out in healed or active disease after the completion of growth potential of bones of the hip joint. This procedure involves the removal of upper end of femur followed by heavy traction so that fibrous tissue is formed and post-operative in bed mobilization to get a mobile hip. Some amount of shortening will occur. Girdlestone procedure provide a mobile, painless hip. About 90% of patients are able to squat and kneel and able to sit cross-legged and walk with the help of a stick. This X-ray of the right hip shows a post-Girdlestone excision arthroplasty procedure. Another surgical option, C. Arthrolysis, means fusion of the joint. This procedure helps to relieve the pain and correct the deformity, but unfortunately sacrifices the motion. Arthrolysis is done less frequently now due to increasing acceptance of total hip arthroplasty. 4D. Corrective osteotomy. Patient presenting with a sound ankylosis in bed position that require a upper femoral corrective osteotomy. E. Hip replacement. There is no role of hemi replacement due to acetabulum is involved. Total hip arthroplasty in the hip with active tuberculous infection is a controversial issue due to the potential risk of reactivation of tuberculosis. But acceptability of early total hip arthroplasty is gradually increasing, with reports that method can be safely used in tuberculous lesion. Total hip arthroplasty in a patient with healed tuberculosis of the hip is now an accepted procedure. Majority performed in the stage of advanced arthritis or in sequelae of advanced arthritis when the joint is unsalvageable. But Hulka and Pandey et al. Recommend surgery to be performed after 10 years or more between the active infection and replacement therapy. Wang et al. Recommend a combination of anti-TB drugs for at least 2 weeks prior to the operation and subsequently for at least 12 months after operation. For stage-wise treatment approach, in synovitis stage, the treatment include analgesic, anti-TB chemotherapy, traction, rest, and immobilization. Surgical interventions usually are not required. In early arthritis, treatment is similar to stage 1. In addition, synovectomy and joint debridement is to reduce the disease tissue load. The prognosis in general is good. In advanced arthritis, the treatment is the same as in stage 2. In addition, there is arthrolysis of the joint with joint debridement. In advanced arthritis with subluxation or dislocation, the joint is destroyed, there is deformities and shortening present. The management is TB chemotherapy, analgesic, traction. The choice of surgical intervention involve arthrodesis or excisional arthroplasty or total hip arthroplasty. Complication of tuberculous hip. Coxa magna and valgus hip due to increase in the circulation of the region affected. Active disease during growing age may interfere with the blood supply of the epiphysis of the femoral head, giving rise to radiological picture resembling of Perthes disease. Tuberculosis rarely stimulate damage to the trochanteric physis and femoral head physis that would result in generalized hypoplasia of the upper end of the femur. Prognosis of tuberculous hip. Early disease. The synovitis or early arthritis may heal, leaving a normal or nearly normal hip joint. Advanced arthritis generally results in fibrous ankylosis. Without treatment, flexion adduction deformities may develop. This requires some surgical intervention. Yay, we have reached to the end of this video. See you in the next one. Take care and bye.